Welcome to the Kerala IRIA Radiology session. As today is International Women's Day 2022, we are celebrating this throughout Kerala in each district by doing free scans, mammograms, ultrasounds, pelvic ultrasounds, and many other activities is done by each district representatives. So I'm happy that we are conducting an online session to give awareness to the public, give awareness to the gynecologists, to the general practitioners. So we have arranged a session and we have two eminent faculties who are going to speak today. So, and we have a chief guest, Dr. Nandini Behari from Gujarat, who is our national IRIA vice president, who has consented to inaugurate this International Women's Day of IRIA Kerala. On this auspicious day, I invite her to inaugurate and give a lecture or speech regarding this. I invite you, Dr. Nandini Behari, to the platform. Dr. Nandini, are you online?
Nandini ma'am should be joining in some time. We can proceed with the inaugural and.
She's not come?
She haven't joined. She'll be joining in any moment.
So, can we start the session or we'll wait?
Maybe you can let us know, doctor. Maybe either we can wait for her, or maybe since the participants also have started joining, I would suggest maybe we can start once she joins. Then maybe we can have a formal introduction of Nandini ma'am.
Anusha?
Good evening to one and all. Dr. Gomti, President of Kerala IRA, Dr. Ramesh Nai, Senior member of the IRA, and we will be graced by the presence of Dr. Nandini in a short while. We have two eminent speakers here, Dr. Anusara and Dr. Tina. Both are dedicated and perseverant lady radiologists out to reduce the cancer load in the patient load that we care for. They are very much bent on and really hardworking to detect the cases early on so that we have a favorable outcome in all the patients who come to us for help. So without much further delay, I think we'll start the academic sessions and hope all the residents who join benefit from this. Thank you.
Anusha, you called Tina. Who's called? You can introduce her.
I introduced both. Dr. Anusara is in charge of women's imaging in MOCM, Kolanjeri Medical College. Dr. Tina is a senior radiologist working in Rajgiri Hospital, and she handles most of the women's imaging there.
Can I start presenting?
You can present. That will be better because Nandini has not come online. I think you can start.
Am I audible?
Yes.
So very good evening to everyone. It's been a very long day for most very lively lady radiologists out here who have been doing so much of work this entire day on the occasion of International Women's Day. So a very happy Women's Day to all the lovely ladies and the gentlemen out there, including Ramesh sir. I think he's the only one who got, I mean, he's the sole representative is what I believe. Coming to this presentation, I was told that this is not just for radiologists, but for physicians and surgeons and a whole lot of other fraternity. So the presentation has been tailored not to be of hardcore radiological stuff, but to give you a bird's eye view of what exactly do we mean by early breast cancer from a radiological perspective. So what is the clinical definition of early breast cancer? So when we say a woman has presented with early breast cancer, we usually referring to a lady who's possibly picked up a lump on her own, maybe 2.5 to 3 centimeters in size. And on clinical examination, we really can't feel any much nodes. At most, there might be a few. And at that phase, we are not looking or thinking of any possible metastatic disease. The radiological definition of early breast cancer is slightly different. Here, we are basically referring to what we mean by impalpable disease, meaning the patient does not feel a lump in her breast, neither does the clinician feel anything. Majority of these patients are asymptomatic. A few of them might present with, at the most, something like a blood-stained nipple discharge. So practically what we are looking at is disease which cannot be felt or by the patient, nor the clinician, but can be seen by the radiologist. So for non-radiologists out there, this is a mammogram, and the area that has been outlined in red is what we are interested in. That cloud-like tissue out there that we are seeing is what we call the glandular or milk tissue, and this is the area of interest. What we need to know is the density of this glandular or milk tissue is something like this. It's a very light shade of gray out here, almost like white. And what is interesting is findings, which might be malignant or benign, almost have density comparable to that of glandular tissue. So that is very challenging for us as radiologists, because to pick up two things with almost similar color lying next to each other can be tough, even for women. Yeah, so now this is a slide which everyone needs to know what we refer to when we say a woman has dense breast. Now the breast on the left is almost entirely fatty, meaning it's got a relatively dark background against which, if there were a finding, whether a malignancy or a benign lesion, it would really stand out, because a white against a black background is really so much, so better visualized. If you compare that to a density out here on your right side, heterogeneously or extremely dense breast, a finding can really be missed, because like I said before, the lesion and the density, they tend to camouflage each other. I mean, the lesion gets camouflaged within the density. What we need to remember is that the sensitivity of mammograms it decreases as we move from a density, from a fatty breast to a heterogeneously or extremely dense breast. And this is the reason why we do not prefer to undertake mammograms in women who are less than 40, because they tend to have extremely dense breasts like this, and we might be subjecting them to an unnecessary procedure where we really cannot pick up lesions. So the first imaging modality of choice in such women is always an ultrasound. Another reason we need to know density and how it impacts a woman is a woman with dense breasts, like in this case, for example, a woman who's in a 60 and has a type 3 or type 4 breast density, meaning it's either very heterogeneously dense or extremely dense, stands at a higher risk of having breast malignancy compared to her 60-year-old counterpart who has a breast density that is almost entirely fatty. So breast density is one of the strongest independent risk factors for breast malignancy. That is something that we all need to know. And there's no better way of knowing how dense your breast is unless you get a mammogram done. So the three main pillars of early breast cancer detection is: one, there is no denying a good machine is a must, a trained radiographer, and of course a radiologist with fair bit of experience in breast imaging. Digital mammogram systems are a requirement these days. They are no longer a luxury. In digital mammograms, what we do is, once we acquire the image, there is a whole lot of post-processing manipulation that can go into, unlike in analog systems, what we were using previously, where once the image is captured, there's nothing really that we can do to make a finding stand out more prominent or appreciate it better. But with digital systems, they are much faster. Within 10 minutes, an entire mammography with 2D and 3D can be acquired. And of course, you can store these images for reference, for your future reference. So each time she comes back, you can just pull out her old folders and then compare to find if there's something that's new that's going on. So digital systems are, I would say, a requirement these days. It's a must for picking up early breast cancer. A word about 3D tomosynthesis before I go into the topic. 3D tomosynthesis or 3D mammography is nothing but acquiring 2D images with the X-ray tube moving in an arc over the compressed breast. So what really happens is something like in CT, where the patient is lying and the gantry moves around the patient, acquiring multiple images. So that's what happens in 3D. The machine, instead of acquiring a single image, acquires multiple images of the breast. Why is this done? Is because of this reason. The breast is essentially a 3D or a spherical structure. And what happens when you compress a spherical structure to get a 2D image is the tissues out there lying in different parts of the sphere, they tend to come close together, they tend to overlap. And like I said, the tissue density and that of an abnormality is more or less the same. So you're just adding to that camouflaging factor, and so you might miss out. So 3D imaging leads to, what happens is that the machine takes multiple images, and so you can, actually it's like reading through the pages of a book. You can look at tissue lying in the intervening planes and can pick up an abnormality. For those of you who are planning a mammogram, and this picture should not be a deterrent, because the compression is not really as bad as it's shown in this picture. This is just for a diagrammatic explanation. So this is what I meant by a 2D and a 3D acquisition. On a 2D image, you really can't see that tumor somewhere out here hiding inside that tissue. While on a 3D, you keep flipping through the images, and then maybe at page 43, you come across the killer. So this is what the tumor looking back at you at image number 43. Another image to show that finding better, the tumor is so well camouflaged within the glandular tissue, but standing back, staring, looking at you on a 3D mammography images. Now coming to the topic at hand, early breast cancer, 3 main findings that we would want to discuss or share with you is: 1 is microcalcifications, 2 asymmetries, and 3 distortions. I'd come to microcalcification first. See, when you look at a mammogram, and if you can actually pick up if you can see calcifications, almost always those would be benign. So what we are dealing, when we say microcalcifications, we actually refer to calcium deposits which are really very small. They are tough to see. In fact, they are very tough for the untrained eye to pick up, because they are in the range of 0.5 to 1 millimeter. So if you look at a mammogram and you can see calcifications from far, they are almost always benign. And why this is very important, because microcalcifications are an exclusive mammographic finding which may point at an underlying in situ malignancy. That's an earliest form of breast cancer called DCIS, or ductal carcinoma in situ. A quick revision as to why DCIS occurs. Now, this is the smallest unit of breast where a malignancy arises. This is a terminal duct, and these are lobules which produce milk, give it to the terminal duct, which carries it to the nipple. So now if you were to take a knife and cut this duct in cross section, this is what we would get. A normal looking duct like this. As with malignancy anywhere else in the body where it undergoes a stage of hyperplasia, here you have a whole lot of normal looking cells which look like the parent cells in the basement membrane cells, but too many of them. Then comes a stage of atypia, where a few of the baby cells start looking different from the parents. And then of course is the stage where we are interested as radiologists, called the stage of ductal carcinoma or in situ malignancy, where the basement membrane is actually holding fort. The basement membrane cells of the duct have not given away, but the duct is full of cancer cells. And so what happens is that these cancer cells start fighting for space. A few of them die off in this scuffle, and what happens is calcium gets deposited as tombstones for these dead cancer cells. So that's the reason why we have calcium deposited inside ducts in DCIS, or ductal in situ malignancies. The last, of course, is a stage that is lost, where the basement membrane has actually given away and the cancer cells are now invading the stroma. And this, of course, is an invasive stage of malignancy. Now, I'll share a few cases with you all. Now, this was a mammogram which most radiologists would want to read. It's a fairly fatty breast, no obvious mass lesions. I'm sure if your eyes went to that speck of calcium out there, let me assure you that is benign. So this is what I meant. If you can really see calcium from far on a mammogram, it's almost likely to be benign. So in this patient, her history was that of a chronic eczematous disease of the nipple, or she kept repeatedly having eczema of the nipple. And so that is clinically concerning for Paget's disease. And mammo was unremarkable for masses, but this is what we see on a magnification view. You see microcalcifications in an arborizing pattern, like branches of a tree going all the way to the nipple. This patient, of course, didn't have any bloodstained nipple discharge, but this finding is very highly concerning for DCIS, or ductile carcinoma in situ. A closer look at that, if you see linear microcalcifications like this is an ultra zoomed in image to show you the finding. These calcifications are 0.5 or just about a millimeter in size. In a linear distribution, if they're seen like shown here, this is almost a Barrett's 4C or maybe even a 5, very highly concerning for DCIS. And this is what we see when we take an MR for these patients. This is not a mass, but what we call a non-mass enhancement. Sometimes the enhancement patterns of DCIS on an MRI can be very scary, but for non-radiologists, we need to realize that this is not a palpable mass, neither is it a mass morphology on MRI, but what we call non-mass enhancement. And this actually shows the entire extent of DCIS, which might be so much more than what we see on a mammogram. At times, patients can have extensive DCIS, like in this case, where you might actually see these calcifications even on ultrasound, or in this case, where there was an entire segment of the breast all the way from the nipple till her pectoral, which was infiltrated with microcalcifications. Now, this was a 40-year-old who had incidental fallopian tube malignancies, and just because she had a malignancy at such an early age, she was sent for a screening mammogram. Again, extremely dense breasts expected at her age, but no obvious mass lesions, nothing on ultrasound too. But there's a very subtle finding out here, and that is the finding. It's what we call a focus of closely grouped pleomorphic microcalcifications seen so well on a magnification mammogram. This, of course, was high-grade DCIS without any focus of invasion. A wide local excision was done for this after we had biopsied this and proven that it was DCIS, and that she's cured. So at least from the breast point of view, she's cured. Again, this was a lady who had presented to us with a mass-like sensation upper inner quadrant of her left breast. High density areas out here are possibly infiltrative disease, but what we need to see is there are a lot of microcals, not just there, but a few of them discrete all along the way going to the nipple out here. So this information is very vital for the surgeon in case if they're planning conservation surgery, because they definitely need to know what they're dealing with before they go in for just removing a palpable area. There might be more to the disease in the breast, and they possibly would leave that out if a breast MRI is subsequently not done in such cases. Another patient, single palpable mass, nothing really on ultrasound, rest of her mammogram looked okay. A closer look at that mammogram, there is a focus of closely grouped microcalcifications, approximately 4 centimeters away from the main mass. So this is information that the surgeon is looking for. You really don't want to remove a palpable lesion and leave behind something like this, which would come back definitely as invasive in a year or so. Now, this was an interesting case, a lady who had undergone an excision biopsy. Of course, it was all the margins were negative. This was a malignancy, and she came to us for her first surveillance mammogram. And this is what we see, architectural distortion because of a prior surgery, but something very close to those clips we see is this, a focus of, again, very concerning microcalcification. Now, this can be a little bit tricky, especially in post-operative cases where you might have calcifications because of benign conditions like fat necrosis, or because of some reaction to suture material, or things like that, a granuloma undergoing calcification. But this was a little concerning, pleomorphic. In such cases, it's worthwhile to see if they had a prior mammogram, before she underwent a surgery, if this finding was there. For us, we really didn't have the prior mammogram before her surgery. So we assumed that this was very concerning. We did a stereotactic biopsy for this, and this was high-grade DCIS. This patient subsequently underwent a mastectomy. Now, this is a very interesting and possibly unfortunate case also. She comes to us in December 2019 as a part of health checkup. Again, heterogeneously dense breasts, no obvious mass lesions that we could see. And the finding out here is this one subtle focus in her right breast. That is the area marked in red. A closer look at that. So this is what we see, approximately 5 or 6 foci of closely grouped, slightly concerning, pleomorphic appearing microcalcification. So we told her that she needs to undergo a stereotactic biopsy for the same. Now, this patient was based in Middle East. She said she was coming back early next year, that's early 2020. And she would definitely, get this done with us. Unfortunately for her, that's when the pandemic started. And somewhere around in 2020 late, she lost her husband to a sudden cardiac death. And this is how she came back in 2021 December, about 2 years after the first mammogram with a palpable mass lesion. So again, that was the 2019 mammogram with a few specks of calcification and a mass lesion out here 2 years later. So that's a mass with microcalcification, and that is how all this started. Now, this another interesting case from last week. This was an overseas patient who presented to us with intermittent episodes of blood-stained nipple discharge from the right side. This was a mammogram which was taken back in Ethiopia. Fairly well-taken mammogram where we really couldn't see any mass lesions, but there were these 2 tiny specks of calcification out here. No obvious mass lesions, not on ultrasound either. And a closer look at those 2 specks of microcalcification. We undertook an ultrasound for her, expecting to see, were there any papillomas inside the duct which were causing this kind of a symptom for this patient, but nothing really. The ducts were actually collapsed. We could see the duct which had these 2 specks of calcium, a little bit of vascularity. Again, that was plus minus. We thought this was a little concerning. Papilloma was definitely not first on our list. Now we thought we would undertake a breast MRI in this patient before we go in for a guided excision. And this is what we see on an MR, an extensive area of non-mass enhancement, linear non-mass heterogeneous enhancement, which is highly concerning for DCIS. So there's so much more to the disease than that can be seen on a mammogram. So mammogram just picking up the tip of the iceberg, and MRI going on to show you the entire extent of what you're dealing with. Another case, now this was locally advanced breast cancer on the right side, skin thickening. This patient, of course, had a mass. Her right breast was riddled with microcalcification. But what was interesting is there is very obvious thickening of the left breast skin too. So this is how the right side looks like. Extensive microcal, not respecting any quadrant. It's there in all the quadrants. And this is a closer look at her left breast. Now this breast was also riddled with microcalcifications. So this is how subtle microcalcifications, of course, this is very extensive, but microcalcifications can be really, really subtle. So this was a case of synchronous malignancy, invasive on the right, and extensive high-grade DCIS with multifocal areas of invasion on the left on biopsy. So DCIS most commonly presents as microcals. A few of these patients, a few subset of these patients can present with blood-stained nipple discharge. And since these are an exclusive mammogram finding, especially if they do not have mass lesions associated with them, they need to be sampled under stereotactic guidance. What we need to understand is DCIS can be associated with invasive malignancies in high as 20% of cases. So picking them up on mammograms is something that we all need to focus on. The second category is what we call distortions. Again, here we are not speaking of, we are not looking at mass lesions. We are not looking at any obvious palpable abnormalities. So distortions are nothing but thin lines or small speculations that we see on mammograms. So it's comparable to, the small kind of wrinkles or small focal depressions that you see on a very well-stretched sheet if you would place your finger just on it. So that's how I teach residents. So the finding can be as subtle as that. What we need to rule out is a history of prior trauma or surgery, both of which can produce this kind of finding, and this may persist for years. The two top differential diagnoses for architectural distortion is one, malignancy, and two, a benign condition that we call a radial scar. This is usually because of some undergoing or a previous inflammatory condition in the breast, which has led the breast to produce a scar around that focus. So now this, of course, is a mass lesion which is producing distortion. It's pulling the skin, the nipple inward, and it's got this spidery kind of appearance emanating from this central mass. But this is not what we are looking at now. This is definitely not early breast cancers. What we're looking at is something like this. So now you have this focus of distortion out here. Again, it's got long spidery legs, but this is actually a 1.5 millimeter malignancies because the tumor size is just about this. And this was, I believe this was the smallest malignancy that we had picked up on our vacuum assisted systems. Again, this is how a small malignancy is picked up. 3D mammography, tomosynthesis is invaluable in picking up these because it so very well highlights those spidery kind of, spidery kind of lines that emanate from this lesion. It's very well seen on 3D. I would like to, that was a 2.8 millimeter sized malignancy. So this was a lady who presented to health checkup again for a screening mammogram, absolutely asymptomatic patient, extremely dense breast. That's a mediolateral oblique and CC views. And this is what we see on 3D. This was a 3D detected malignancy. And if you can see that distortion out there, something scar-like area showing up as you flip through the pages of that book of the study of her breast. Now, exactly on the mediolateral oblique view, that is a finding out there, the area of distortion seen so well. And in this case, in fact, we went ahead and did a biopsy. This was reported as negative. So we were concerned possibly we are dealing with radial scars. So we advised an excision. She did undergo an excision because once in a while, radial scars do undergo an upgradation on final excision. So even if your sampling comes back as negative, what we need to remember is such findings need to be excised because there's always a chance that this might get upstaged to malignancy later. So this was indeed a grade 1 invasive ductal carcinoma and final excision. Now, this is not an early malignancy, but I would want to highlight how beautifully tomosynthesis actually picks up smaller distortions. Mass lesion out here in the inner quadrant of the left breast. And that's the tomosynthesis image showing that mass and speculations so well seen. And this is what you get to see as you flip through the further images, multiple other smaller areas of distortion along the duct going all the way to the nipple and in fact even posterior to the main lesion. So 3D tomosynthesis, a must, I would say, these days, if you are looking at picking up early breast cancers. The next finding is that of this asymmetries. Now, this is the last finding that we as radiologists give importance to when reading a mammogram. Asymmetry is based on the principle of comparing two sides, something that we very commonly use in neuroimaging. We look at the right hemisphere, left hemisphere, and try seeing if there are any differences on both sides. So this asymmetry in breast is when we pick up certain unilateral deposits of tissue, which are not mass, tissue that are not mass, and they are not seen in the same side on the opposite breast. So this is what we refer to by asymmetric deposits of tissue. Now, finding like this can be quite common, like you see it on one view, but on the other, it tends to spread out. It's not seen very well. This is what we call summation of tissue. This, what happens is when the breast is compressed, most of these tissues, they tend to lie on top of each other. So maybe on one view, they tend to show up as a pseudomass. So this is actually not a pseudomass. With experience and with reading multiple images, we know this is nothing but summation tissue. But once in a while, our eyes need to pick up asymmetry. Like in this case, there's an obvious, this patient did come with a mass-like sensation. The tissue on the left side in the same region is much higher in density as compared to the right. She has a whole lot of microcalcifications out there. But what is interesting is there is some finding out here in the medial aspect of her right breast with no corresponding finding on the left, something hidden within this tissue out here. So we look at the next image, that is a mediolateral oblique, where that finding tends to fall away from the rest of her breast. So this definitely is a finding. This is not tissue. And this, of course, was invasive malignancy with a whole lot of DCIS and metastatic nodes. On ultrasound, this is what we see on the right side. This also was a focus of invasive malignancy on the right side. This was a recent case, a 65-year-old who presented with increase in size of left breast with changes on her skin. There was evidence of purity orange. And now this is the kind of asymmetry that we are talking about. There is no mass lesion. You really cannot see a mass out here, but there's definitely higher, there is an asymmetry in this tissue compared to that on the contralateral side. This tissue looks more dense. There's definitely more skin thickening on that side, but again, no mass or microcalcifications. And that's how it seems on the mediolateral oblique view. This is what we call a global asymmetry, when it involves more than one quadrant. Many tumors are notorious for this finding. Commonest among them being invasive lobular cancer, where the tumor tends to infiltrate and go along the normal breast architecture without distorting or actually producing a mass lesion. This was a case of invasive lobular carcinoma. So the next question is, if you really cannot see these on, on ultrasound, how do you biopsy them? Because majority of the findings that I just spoke about are findings that you see on mammogram. So what we do is stereotactic guided biopsies, meaning these patients undergo sampling under mammographic guidance. And these are the findings. Almost always for microcalcifications, we undertake stereotactic biopsies. Distortions and asymmetries, if we can see anything on ultrasound, we would always prefer doing an ultrasound guided biopsy because it's technically it's much easier. It's less expensive and it's done much faster as compared to a stereotactic biopsy. In our hospital, we use a vacuum assisted system where we introduce a needle into the breast with the patient seated in mammogram. And what happens is the needle is placed right under the area of abnormality. If this were a focus of microcalcification, the trough or the well kind of is placed right under those calcifications, and vacuum is applied from an extraneous source, which causes these microcalcifications to drop into this well. So what actually happens is, once this drops into the well, a blade moves forward and keeps cutting these the breast tissue at that point and sucks them out. So what we get, this is the needle that we use. It's a 9-gauge needle, and this is the vacuum system that is used to generate the vacuum from an extraneous source. These are how samples look like. In fact, the samples that we take are radiographed later so that we can pick up the ones with microcalcifications, and those are sent separately to the pathologist for ease of reading, so that they really don't have to go through all the samples, but specifically look at the ones with microcalcifications. So to end this presentation, what we need to know is breast cancers don't always start off as palpable masses. Unfortunately for us, we really do not have a screening program running in our country. So we would still keep having patients present with masses or with other symptoms of breast cancer. Only once in a while do you get to pick up and see early breast cancers on mammography. Microcalcifications, asymmetries, small distortions, small masses, all these findings are easy to miss on ultrasound because ultrasound is so much operator dependent, depends on the kind of machine that you are using. Hence the need to do mammograms to pick up these early breast cancers. And what we need to know is slow growing cancers. We're not talking of high grade interval cancers, which might come up in months, but slow growing cancers might actually take even 2 years before they can become clinically palpable. So you might be picking up a tumor at least 2 years ahead before they are clinically felt by the clinician or felt by the patient. So thank you so much for your kind attention.
Hello. Am I audible?
Hello. Hello.
Dr. Tina, the wonderful
Hi.
presentation. Wonderful presentation. Good evening, Dr. Nandini. Can you talk now?
Yes, I can. Good
Thank you.
evening, Team IRI Kerala, Gomti ma'am, and all the lovely ladies. Happy Women's Day. And I'm so happy to see you all again and also to see the wonderful presentation. Have a great evening. And I have also posted a small message, which I hope Gomti ma'am will send to all of you on my behalf. And I wish you all a lovely evening and great success. Is Gomti ma'am there?
She's just gone off for some time. She had some emergency. She'll come back later.
Right, I have to go for a meeting, but I'm so happy to see all of you. And again, wish you all success and happy Women's Day. Bye-bye.
Thank you. Thank you, Dr. Nandini.
Bye-bye.
Thank
Yeah.
you. Bye.
Thank you. Bye.
So, Dr. Tina, that was a wonderful session highlighting the importance of tomo and MR mammo, which picks up far more cases than routine mammography, and very, very interesting cases which would have been totally lost, and the patients would have suffered if not for these advances. Very nice. I hope the residents will benefit from this. Now we can go on to Dr. Anu Sara's talk. Anu, please continue.
Shall I share my screen?
Yeah.
Can I start?
Yes, yes, Anu.
Good evening, everyone. My topic for discussion is evaluation of palpable breast masses. And as Tina said, that this session is not a hardcore radiology. It's for, as we are expecting a lot of referring clinicians to attend this meeting. It's tailored for general discussion. So before going on to the session, I want to thank all the organizers for inviting me to talk in this session, especially Gomati ma'am for inviting me, and also Anusha, thank you for the introduction. Also want to thank Rijo Matthew sir and Ramesh Noy sir for their support. So now going on to the topic. So how can we evaluate the palpable breast abnormalities? So first is, most important is history, but I wouldn't talk more on that. Then physical examination. Here the point to be noted is some normal structures can be mistaken as palpable breast masses, like a prominent rib or a costochondral junction or a prominent fat lobule or a discrete ridge of normal fibroglandular tissue. So imaging is very important to see whether what the palpable mass is it a lesion or is it a normal breast tissue. So the imaging modalities commonly used are mammography, ultrasound, and breast MRI. So mammogram is generally done for women more than 40 years if they are presenting with a palpable breast mass. And the general views taken are the craniocaudal, mediolateral oblique view, spot compression views, and magnification views. So if we can palpate a mass, it's always better to keep a marker on the skin at the site of palpable abnormality and then take a mammogram to have a better correlation with the finding. So if the mammogram is done less than 6 months back, we can do only a single side mammogram for the on the side of the patient's complaint. Another point to be remembered here is that in approximately 13% of cases of breast cancer, the mammogram can be normal. So if we have to assess with other modalities if we are getting a normal mammogram, especially in cases of dense breast.
So which all are the clearly benign findings on a mammogram, where we can stop with the mammogram itself? That is, it can be an involuting fibroadenoma with all this popcorn calcifications, or it can even be a normal intramammary lymph node, or even a hematoma with fat within the lesion. Sometimes the palpable mass can be galactosate, especially in lactating women, or it can even be a lipoma. So in all these cases, mammogram is diagnostic and we need not do further evaluation. These are Barrett's 2 lesions and follow-up is not necessary. In all the other cases, for a Barrett's 3 and 4 and 5, further evaluation or biopsy is required. For Barrett's 3, we have to follow up the case. And in women less than 40 years, the preferred modality is ultrasound. And the reason is, and also in pregnant and lactating women. So the reason is that younger women have a denser breast. So the lesions are less well demarcated in younger women on a mammogram. For example, in this case, we can see that there is a equal density mass sitting there, but we can't see the margins. It's obscured because of the density of the breast. On doing the ultrasound, it was seen as a benign cyst. So this is the Barrett's 2 lesion, which can be left alone. So ultrasound helps in in evaluating young women and also pregnant and lactating women. This is another case. This is a lactating woman. She's having a lump, and here we can see there is a complicated cyst here. And on turning the patient to the lateral position, there is layering of the cyst. So it's a galactosate. So certain pathologies can be diagnosed with confidence on ultrasound, and ultrasound helps in such cases. An MRI, it's generally not used as a primary imaging modality. It's usually used as a problem-solving tool. Like if you can't biopsy a lesion, like you're only seeing the lesion in a single view, or you can do a MRI and see whether it's really a lesion or whether it's a glandular tissue. And so with increased confidence, we can biopsy. MRI is also done to see the extent of the disease in cases of malignancy. An image-guided biopsy can be either ultrasound-guided or stereotactic biopsy, as Tina has discussed, or guide-wire localization. Aspiration by ultrasound guidance can be done for cyst and abscess. Here, this is an abscess with a needle inserted for aspiration. So next major question which everyone asks is whether we should do FNAC or biopsy. So we have to remember that FNAC has a substantial rate of insufficient samples ranging from around 15 to 74%. This was proven in multiple studies. Certain multi-center trials were also conducted. So FNAC is no longer advocated for evaluation of breast masses. Only core-nasal biopsy should be done, and FNAC is only done if it is a cyst where we need to aspirate or if it's an abscess. And one more point which we have to note, that if after biopsy we are getting a discordant radiopathological result, we have to do a repeated biopsy or advise for excision. And if such a careful monitoring concordance, radiopathological concordance cannot be done routinely, then at least we have to do a short interval follow-up for the benign biopsy results. So all the Barrett's 3 category, which is probably benign, has a less than 2% malignancy rate. So these lesions can be put on short interval follow-up, that is 6 months for 2 years. So this algorithm can be followed while you are dealing with the palpable breast mass. If it's more, the patient is more than 40 years, start with a mammogram itself with a marker on the lesion and do a correlative ultrasound. And depending on the BIRATS category, further management can be done. If it's BIRATS 3, we have to do a short interval follow-up. BIRATS 4 and 5, we have to biopsy. While a younger woman needs a targeted ultrasound first, and if negative, we can go and do mammogram. I'll discuss few cases which we have evaluated in our department, who presented as palpable lumps. This is the case of a 52-year-old with a lump in the left breast for 3 months. So we can see that there is a subtle architectural distortion in this region in the left breast at around 12 o'clock position, and this was corresponding to her site of palpable concern. So ultrasound was done, and there was a region of ill-defined shadowing. A definite mass could not be seen, but an ill-defined shadowing with architectural distortion was also seen on ultrasound at 12 o'clock left breast. So ultrasound guided biopsy was done, and this was invasive carcinoma. This is a 63-year-old lady with lump in the right breast for 5 months. Here, as Tina has already said, we can these are the microcalcifications, which is seen in the right breast inner quadrant with a segmental distribution extending right up to the nipple. And ultrasound correlation showed it was visible on ultrasound also. So ultrasound guided biopsy was done, and this was the BCIS. Now, this is a case of a 39-year-old lady with a lump in the left breast for 2 months. So there is a asymmetry and architectural distortion in the left breast, lower inner quadrant. Ultrasound showed that it was a very ill-defined lesion with necrotic changes, diffuse edema in the skin and in the breast. A biopsy was done. This was granulomatous mastitis. This case, this was a 34-year-old lady with a lump in the left breast and nipple retraction for 4 months. She came for ultrasound, but as you can see that due to the diffuse skin thickening and edema, a deeper breast could not be imaged. So mammogram was done, and we can see that there is a global change in the left breast, global asymmetry, thickening of all the trabeculae, skin, nipple retraction. So an MRI was also done for her, and we can see that there's an enhancing lesion, a diffuse enhancement in the left breast, which was extending into the pectoralis muscles. So biopsy was done. This was an invasive cancer, and she was given chemo-RT, and she was treated with MRM, but sadly she expired after a year due to brain metastasis. So this is a case of inflammatory breast cancer. What is inflammatory breast cancer? Is there wouldn't be a dominant breast mass. There can either be multiple small lesions, or you might not see a lesion, but there is diffuse thickening of the trabeculae skin, and cancer cells will be there in the dilated lymphatics in the skin. So differential for this inflammatory malignancy is a mastitis. This is quite an interesting case. This 56-year-old lady came with a painful lump in the breast for, she had the complaint for around a week. Mammogram was done, and it was a relatively well-defined lesion, circumscribed margins. Part of the margins were obscured due to the glandular parenchyma. These are the MLO views. Ultrasound showed that the lesion was kind of necrotic, with thick-walled lesion was seen. So this was a definitely suspicious lesion. It was categorized as BIRATS 4B. Ultrasound-guided biopsy was done, and the report was very surprising. It was a plasma cell neoplasm. So further imaging was done for the CT thorax and abdomen, and all the lab markers were done. And in the CT, we could see that there were multiple lesions in the sternum, ribs, vertebrae, and this is a case of a multiple myeloma with a deposit in the breast. In this case, she had a lump in the breast for around right breast for around 3 months. So it was very much posterior. Posterior margins could not be imaged on a mammogram. An ultrasound was done, and this lesion was taller than wide, and it was looking suspicious, and it was hard on elastography. With the lesion had vascularity. Ultrasound guided biopsy, it was a triple negative invasive cancer. The triple negative cancers have a poor prognosis, and sometimes these can have a benign appearance on ultrasound with well circumscribed margin and posterior acoustic enhancement, which is usually seen in benign cysts. So next case is a 30-year-old lady with she's breastfeeding. She's saying that she had trauma to the breast, and there was a nipple ulcer near the nipple, and also she had lump in the breast for a year, and she came for ultrasound. So ultrasound done, this was a strange looking lesion with angulated margins, and this lesion was definitely suspicious for malignancy. So mammogram was also taken, but mammogram did not contribute much to the characterization of the lesion, because it was because of the dense breast. But some amount of microcalcifications could be picked up on mammogram. Ultrasound guided biopsy was done. This was an invasive carcinoma grade 2, and FNAC of the lymph nodes were also taken. Then there were lymph node metastasis. So her MRI was done, and we can see that there are multiple enhancing lesions in the right breast with multiple enlarged lymph nodes in the level, all the levels 1, 2, and 3. So point to note here is, this is a breastfeeding lady. So mammogram here, it was less sensitive. It was ultrasound, which in which we could see the lesion clearly. So ultrasound is a we should always correlate with ultrasound in young women and lactating women. And if a lactating woman is undergoing mammogram, she should always breastfeed and express the breast milk and then undergo the mammogram. Otherwise, the breast density will be more, and the lesions will be still more difficult to detect the lesions. So what is pregnancy-associated breast cancer? It is seen during pregnancy or within a year of delivery. And the problem with this type of tumor is, due to lack of awareness or due to the difficulty in diagnosing such lesions, it is generally seen at advanced stage and has a poor prognosis. In this case, it was a history of infertility, lump in the breast for 2 months, breastfeeding. There was a suspicious looking lesion on ultrasound, which was biopsied, and also mammogram was done, which showed architectural distortion in the right breast. And we can see that there were suspicious looking microcalcifications in the lesion. So as a pre-op workup, MRI was done. So this whole region, enhancing region, is tumor. And this is a normal breast, which is larger because she was preferentially feeding from the other side, from the left side. So this is a hypertrophy left breast, and this is a tumor. So biopsy showed that it was an invasive carcinoma. So this case, she had a lump in the breast for a year, right breast. An ultrasound done showed that it was a huge fat containing lesion, and there were no obvious solid areas on the ultrasound. So a mammogram was also done for correlation, and this was seen to be a fat-containing lesion, lipoma. An MRI was done as for pre-op workup for her, and it was seen that the lesion predominantly was within the pectoralis muscles. So this is a case of lipoma. So next case, I just put this case to show the importance of doing ductography. We do ductography once in a while for some cases when there is some diagnostic dilemma. So in this case, she had a nipple discharge and lump in the from the left breast. And on mammogram, some microcalcifications were there. She was not willing for further evaluation with MRI to see the extent of the lesion. So in this case, we did a ductogram. So here, the contrast was injected through the duct from where the nipple discharge is coming. And we can see that there are multiple filling defects and the duct is narrowed in some regions. So we could see the extent of the disease in a better way with the ductography. So conventional, in this case, biopsy was a DCIS. So uses of conventional galactography or a ductography is, you can see the extent of the disease, and you can see the peripheral and central lesions, and it guides a surgical excision. But contraindication is allergy to iodinated contrast. So how it is done? Usually a 24 gauge or a 26 gauge IV cannula set is used, and we have to cannulate the duct, and contrast is injected till pain or resistance, and then a mammogram is taken. So this next case also I want to show another useful investigating modality, which is whole body diffusion. So in this case, actually she didn't present with a breast lump. This lady came with a cervical adenopathy for 1 month, and she came for an MRI of the neck. So here we can see that there are multiple necrotic lymph nodes in the left side of the neck, the left cervical region. And as a protocol in our department, when we do evaluate for metastatic workup, we do a whole body diffusion. So whole body diffusion was done for this lady because to look for nodes in other region, and surprisingly, lesion was area of restricted diffusion was picked up in the right breast. We can see that there is this right spot here in the right breast. So this was a malignant lesion, which was, and later the mammogram was done for this lady, which showed that it was the Virat's 5 lesion with microcalcifications, lobulated margins, but she never complained about this lesion. So what I want to highlight from this case is that whole body diffusion is in the recent studies, many of the recent studies, whole body diffusion is showing as good sensitivity as a PET-CT, and we have seen that in many cases it picks up all the metastatic nodes very clearly. So it's also known as a poor man's PET-CT because the whole body diffusion can, the charges are much lower than the PET-CT. So it was an invasive ductile carcinoma of the breast, and from the cervical lymph node biopsy, it was a TB lymph node. So concluding, the take-home points are, when you're evaluating a case of breast lump or a palpable breast mass, for women 40 years old or older, you can start with mammogram and, if needed, do a ultrasound correlation. And breast ultrasound is preferred for younger women and in pregnancy and lactation. And probably benign lesions, Virat's 3 should be put on short interval follow-up, which is 6-month follow-up. And Virat's 4 and 5 lesions should be biopsied. And FNAC has higher rates of insufficient sampling, and biopsy should always be preferred for evaluation of breast masses. And if lesions are seen only on mammogram, we have to do a stereotactic biopsy, a guide-wire localization. Ultrasound-guided biopsy can be done for lesions seen on ultrasound. And we have to immediately find out, recognize that there can be discordant results between imaging and pathological results. So in such cases, we have to repeat the biopsy or advise for excision. And breast MRI is not used as a primary modality, but can be used as a problem-solving tool and to see for the extent of a malignant lesion. Whole body diffusion-based MRI is a useful investigation for metastatic workup. Galactography is useful for evaluating intraductal lesions to look for the extent of the lesions in selected cases. Thank you for your patient listening. Happy Women's Day to everyone.
Thank you, Dr. Anu, for the wonderful session. I think you have cleared a lot of the dilemmas faced by radiologists regarding benign lesions which could mimic a malignant lesion in clinical practice. Another thing is the importance of ductography for problem solving, and diffusion, as you said, every patient cannot afford a PET scan, so that could be a riddle solver and point in the right direction. So now I think we will go for the questions. Is that it, Soumya? Dr. Gomti?
Yes, doctor, we can
Hello?
the Q&A.
We'll go for the polls.
Yes, doctor. See, we have created this quiz for the participants so that we'll be able to understand like where are we in understanding the breast imaging. And I would request all the participants to join the poll session now for 1 minute. Accordingly, we'll go for the
without the question, start with the new. And once the Q&A is done, we can go for the
Soumya, the session is ended. Soumya.
Doctor, I'm audible.
Yeah, you're audible. You're ending the session?
No, we'll go for the Q&A now, and we can see the poll results later so that we can stick to our timing.
Okay, okay. Okay. Anusha, you carry on, Anusha.
Okay.
Okay.
So the first question, open to poll. Which is the primary imaging modality of choice for evaluating lump in breast in a pregnant or a lactating woman? Options are MRI, mammogram, and ultrasound. Is the time up, Soumya?
Okay, so we are getting the answers in our chat box. That's fine. So we can read out the question and we can read out, we can answer accordingly. So that will be better.
Okay. So many participants have put up the answer as ultrasound in the chat box. Okay, that is the correct answer. Then second question, which of these shouldn't you use on the day you go for the mammogram? Underarm deodorant, lotion or cream or perfume, mouthwash, both A and B. Okay, the answers on the chat box that have come up now are both A and B. It is true. And also, I think you shouldn't use talcum powder also. Third question, risk for malignancy for Birad's 3 lesion is, you have to mark only one answer, less than 90%, less than 2%, less than 50%. Okay, the answers in the chat box, 2% or the B option. So that is correct. Fourth question is first investigation of choice for assessment of blood-stained nipple discharge. Options are ultrasound, ductography, mammography, and breast MRI. So we have a variety of answers coming up on the chat box. Ultrasound should be the first modality for investigation. Then we can go ahead with ductography if we suspect an intraductal lesion, or as required proceed to breast MRI. So some have written ultrasound, some have gone straight away for ductography, and some have gone for MRI as a first modality. The question is, which is the first investigation of choice? So that is ultrasound. Fifth question, which is the first imaging modality of choice for a breast lump during lactation? During lactation. First is clinical breast examination, second is ultrasound, third is breast MR, and fourth is mammogram. A lactating patient, what is the first imaging modality? ഞാനൊരു വെബിനാറിൽ മോഡറേറ്റർ ആയിട്ടിരിക്കുകയാണ്, അത് കഴിഞ്ഞ് എൻ്റെ വിളിച്ചാൽ മതിയോ? Okay, the answers are ultrasound only. So ultrasound can be used as a first modality. Then depending upon the need, if we have a high suspicion of malignancy, we can go ahead with MR if there are very dense tissues, or if we need further evaluation, or mammogram. So first modality is the question, so that is ultrasound.
Thank you, doctor. We have a few questions in the chat box itself. So the first question is, what are the indications for Tactography? Speakers would like to take up the question.
Dr. Anu?
Ductography is generally done if you're suspecting intraductal lesion. Like if there is a blood-stained nipple discharge, and if you're after ultrasound, if you're seeing intraductal mass and you want to see whether there are multiple masses, you want to guide the surgeon and tell the extent of the lesion. So it's always useful to do a ductogram, though it's rarely done nowadays. at least for patients who cannot afford a MRI, ductogram is very useful.
Okay, thank you, Dr. Anu. Soumya?
Yes. The second question is, how can screening be
How?
how can screening be improved?
Be improved. Dr. Tina?
That's a very non-specific question because for improving screening, we really don't have any guidelines set at our, neither at the government level nor at the level of radiological, guidelines as laid by the like things like IRA or BC, where we recommend once every year in women who are over 40, but then that needs to percolate into the society, as in women need to come out on their own, need to understand the importance of screening, why screening is important, because it picks up early breast cancers. So there is no real way of improving breast cancer breast cancer screening apart from increasing awareness, since there is no strict guideline, which or neither is mammogram covered by insurance like it's there in the West. So no one is going to come on their own to get it done unless there is a need. So we will continue seeing only diagnostic mammograms for a very, very long time. So if we were to improve screening, I would say possibly improve awareness. That's all. That's all that can be done at this level right now.
Thank you, Dr. Tina. To add to that, if there is a strong family history, maybe 10 years prior to the detection age of cancer in the family member, maybe that individual can start screening.
Thank you, doctor. The next question, can I read out?
Yeah.
Yeah. So the next question is contrast enhanced mammogram useful in detecting no mass enhancement in patients at high risk of breast cancer with no palpable or chronologically visible lesions?
Can I take that question? Yeah, I have had a personal experience of working with contrast digital mammography. In fact, the first installation was in the hospital that I had worked in Miyot in Chennai. So, what we are looking at when we are speaking of non-mass enhancement is basically DCIs. So it is very, very subtle. So with contrast digital mammography, even masses at times do not take intense enhancement. That is, people who practice this might choose to differ, but non-mass enhancement is very subtle, which I think there is no, there should be no difference of opinion about it. MRI is the modality for picking up. The breast is not under any kind of compression when contrast goes in, and very subtle uptake can be seen so beautifully on MR. I think nothing replaces MR in that. And moreover, the spatial resolution of contrast digital mammography is, I think that's something that we really cannot compare to breast MRI. Breast MRI actually shows that enhancement so well, while on a contrast digital, all you see is just a faint uptake, and that could be a tough call to decide whether it's actually a non-mass or not. Mass, yes, you still can. Non-mass, I would say if you had an option of a breast MRI, always breast MRI should be the investigation of choice.
Yes, thank you. Soumya, any other questions?
I think we have taken up all the questions, but in case if you would like to give a takeaway message on the screening of breast cancer, the surgical doctor, can give points where we keep in mind to evaluate.
So I think we have had two wonderful talks today on breast imaging by two very eminent lady radiologists in the Ernakulam district, and both have pointed out nuances of benign lesions as mimickers and the use of the imaging modalities in each patient as per case requirement. So concluding, like the question came up on breast screening, as Dr. Tina pointed out, there is no hard and fast rule yet in India or from the side of IRA or BC. But 40 and above, we can include regular screening and 10 years prior to the age of the family member who detected the who was detected with breast cancer, or in a particular person as per the complaint that the person comes with. Another thing is we can increase the awareness of breast cancer and make self-examination every month percolate down to the far reaches of society, so that the early detection becomes a daily routine, and the long-term survival is far improved in the society. Any other questions? Anybody?
I think, Doctor, we have answered all the questions, whatever
Okay.
we asked for.
So I think
We can wind up.
we can wind up. Thank you, Dr. Anu and Dr. Tina, for the wonderful sessions. Dr. Gomuti?
Yeah, it was a wonderful session. I could hear only partly because I was in another session. So anyhow, it was wonderful. Anisha, thank you so much for moderating the session. And I thank the Kerala IRA. Anisha, you can take to the platform. You can thank.
Okay, thanks one again. And thank you, MedPiper and Soumya and team for the seamless and lack of interruptions and a smooth session today. I hope everybody benefited from the session. So thank you once again. I think we can log off. Okay, bye.